Coming. My name is Claudia Lenhoff, and I'm the Executive Director of the Champaign County Healthcare Consumers. And basically, today we're hoping to do a lot of education on the role of nurses and RN nurses and nursing staff in hospitals and patient health and safety and mortality and so on. And we're actually on the verge of kicking off a consumer and community education campaign to talk about these issues. And this is sort of a first version of a consumer guide that we have put together that is important for consumers, patients, community leaders, legislators, anybody who has a stake in healthcare and in making sure that our hospitals are staffed well and safely. And part of the reason that this comes about is because, as people know, we'll talk about this a little bit more later on, but as people know, there have been a lot of studies recently, just in the past few months, making direct links between the level of RN nurses in hospitals and patient mortality. And these studies basically just confirm what nurses have been saying for about 10 years or so, that with cost-cutting measures and cutting back on staffing and so on, that patient health and safety has been endangered. And basically, since those studies have come out, that has fueled a lot of the nurse activists and consumer health activists to start demanding information about staffing levels and to start demanding accountability for staffing levels. But at the same time, what has happened, the hospital administrators read all the same news articles we do. They read the same reports. They know the importance of staffing levels and that this is what's on people's minds. And so part of what's happened is that as advocates start asking more questions about staffing levels, it gets harder and harder to understand what the hospitals are saying about what their staffing levels are. In other words, the hospitals have developed sort of new language that makes it a little less clear who's actually providing the care, who is actually involved in direct patient care, and so on. So part of our education effort is an effort to help decode that language so that when people want to try to get that information, they know what kinds of questions to ask, and they can sort of recognize some of the euphemisms and sort of get through them. And one other thing that I'll say before we turn, I'll tell you about the rest of the meeting and we turn to the video, but one other thing is that you'll hear a lot of advocates and also hospital administrators and so on saying that consumers need to take responsibility too. They need to make choices about which hospital they're going to end up in and choose based on this kind of information. Well, the reality is this kind of information is hard to get. The other reality is that a lot of times you don't choose when you're going to be hospitalized, and you don't choose which hospital you go to. You go to where they take you or where your health plan takes you. And so I think that from a community perspective and from a public health perspective, we all need to be invested in good quality staffing at every hospital, not just in our community, but anywhere. So for today, what we're going to do is actually watch a little video clip. It's about 9.5 minutes long, and the video clip is actually from Nightline from about 6 years ago, and it's talking exactly about these issues. But you'll see that some of the industry's response at that time was that, well, the data aren't in. There's no research to back up what the nurses are saying. And so we sort of want to step back in time a little bit. The video clip does feature Diane Friedman from Covenant Hospital, so you'll see some comments from her. And then after that, I'll actually just turn it over to Faith Hinson and Pat Wittig, who are going to talk about very concretely. We want to really help people understand why the staffing levels matter and how they translate, how a nurse's job and what she can and can't do translates into patient health and safety problems and mortality problems. So if people are ready, I'll go ahead and start the video. Y'all can pull your chairs around if you want. In this room, it's hard to do a video in during the daytime because of the glare, so I'm hoping that people will be able to watch this. There's more on that video, but it involves a panel of people, and if people want to see that, I'm happy to let people check out the video. One thing that I do want to say is that when Diane Friedman says that the plan that they developed for re-engineering was a good one, and it was developed by nurses, I mean, my question is like, which nurse? But I think, you know, one of the things that's important to hear is that recently when people have been talking about quality of care and nurse staffing levels and things like that, they have, Prevena Covenant has admitted in the newspaper that the plan that they had didn't work, and that they're like trying to build up their, you know, they try to talk about building up their levels, you know, so just, you know, that's sort of like fast forwarding to the future. But why don't I go ahead and turn it over to Faith.
Right. My name is Faith Henson. I'm a intensive care nurse in San Francisco now at UCSF Medical Center, but my family and home is still here in Champaign. That's why I want to work very hard to improve patient care in Champaign. But to continue what Claudia was saying, seeing this video again is very disheartening. I mean, things have gotten worse rather than better. And to go along with the re-engineering plan that Prevena Covenant spent tens of thousands of dollars for, if not millions, they never implemented it as it had been written on paper. Ernst & Young came up with a plan, not that it was a good plan, but they never actually implemented the plan because it would have been too costly to staff the way the plan had determined. It was dumped within a year or two, and now the vice president of nursing said she never even liked the plan, so they wasted lots of money on the plan. But the situation has deteriorated in spite of that. So, first of all, as you know, this is an educational meeting. Pat and I want to explain what nurses do, and so I'm going to cover a little bit of the dry technical information about the studies that have been done, but first I want to say I feel the public, and it's not the public's fault, don't really understand the importance of nursing. And when we learn in nursing school, this is one of our parts of our job description, is to educate the public. So basically the reason that people are hospitalized, that they go to the hospital, is that they need nursing care. They need 24-hour care by a registered nurse. Physicians, as you know, only spend 5-10 minutes seeing their patients in the hospital each day, and they rely on the registered nurse, and whenever I say nurse, I mean registered nurse, to care for their patients the rest of the time. We are not the ears and eyes of the physicians, as many people will say we are. We make our own decisions. We are our own ears and eyes. In many ways, the doctor's course of care is determined by the RN at the bedside. What we report to the doctor influences his or her plan of care. In many ways, we know the patients better than the physicians, and the physicians often say this. It is the RN who decides when to call the doctor when a patient condition is changing. It is the RN who decides when or if to give the medications the doctor has ordered. An RN does not simply give out whatever medications the doctor orders. That could kill the patient. A patient's status changes every minute, and it is the RN who determines how and when to carry out the doctor's orders. On a separate issue, many of the hospitals, we're trying to demystify what hospitals talk about in the media, and this is sort of a separate issue. Hospitals, you'll know, complain that the nurse's salary is such a large percentage of their budget, but it doesn't take an Einstein to know that that is as it should be, and it probably should be a higher percentage of their budget. Nursing is why patients are in the hospital. And having a registered nurse at your bedside is not a luxury. It is your right, and it can save your life. So today we're going to concentrate a lot on the new nurse-to-patient staffing ratios, because we hear about this nationwide. But it is not news to us, the nurses in this country, that our workload has increased, that the patients in the hospital are much sicker because they're sent home much earlier, and that we, the nurses, do not have time to provide the care that we are trained to give. For years, hospitals have dismissed our complaints. This is what Laura Gasparos was saying. And our arguments as anecdotal, asking us for proof that harm is being done. For years, we had no proof. But finally, after many frustrating years, several highly acclaimed reports have been issued and lend credibility to our claims. And these I would like to briefly summarize for you, and Claudia has also, I think, summarized quite a bit of this lavender thing. And we have copies of the full reports if you want. So, first, in 1998, the Institute of Medicine, which is a part of the federal government, published its report in a book called To Err is Human, and it stated that 80,000 preventable deaths occur each year in our hospitals. And let me emphasize, these are preventable deaths, unnecessary deaths. To help you better comprehend that number, it is equivalent to a World Trade Center crash every 2 weeks. And you know how badly we feel about the number of lives lost on September 11th. So this is every 2 weeks of every year, that many people are dying in the hospitals. This report made the headlines in all the newspaper, it was on TV, but then it seemed to fall on deaf ears. It was also estimated in this report that the total national costs, loss of income, disability, healthcare costs, etc., of preventable adverse effects in the hospital, not deaths, are estimated to be between $17 billion and $29 billion a year. With that, this is just an aside, with that amount of money, we could certainly insure many of the uninsured in our country. The report goes on to say that not all costs can be measured. There's also a loss of trust in the system, and as a nurse, this is heartbreaking. Patients experiencing longer hospital stays or permanent disabilities, and healthcare professionals' loss of morale and frustration at not being able to provide the best care possible. And of course, as a nurse, we see this. And of course, society in the end is the one that suffers the most, and yet still little notice was being taken. Then in the summer of 2000, the RAND Review, which is a very highly esteemed think tank, their article called Full Disclosure, Time for the Naked Truth About Healthcare, continues this discussion, instigated by the Institute of Medicine, and they say that 98,000 preventable deaths a year occur in our hospital. The author of this report asks, and I quote, "Is it that a danger as widespread as poor health care receives only passing notice, while isolated problems, defective auto tires, faulty airplane rudders, can preoccupy journalists and policymakers until the problems are fixed? Given the public outcry over a few deaths from bad tires, the lack of public outrage over thousands of medically preventable deaths is truly astounding." And this, I find, is truly astounding. Then in May of the year 2002, the New England Journal of Medicine published a study by Harvard School of Public Health researcher Jack Needleman and his colleagues, which was the first major study to document on a national scale the damage to patient health caused by inadequate nurse staffing levels. In particular, the study shows that the nursing shortage in our hospitals has resulted in increased deaths and illnesses. Dr. Needleman stated that he, this is a quote, estimates that hundreds or perhaps thousands of deaths each year are due to low staffing. So now they're taking all these deaths, these preventable deaths, and saying that many of them are caused by the low staffing of nurses. How much clearer can this be? More nurses at the bedside will obviously save lives. But even this study did not seem to make the public take action. But finally, 2 months ago, the Journal of the American Medical Association, one of the most respected journals in our country, published the results of a University of Pennsylvania study by Linda Aiken, stating that, quote, "For every additional patient added to a nurse's caseload after they have 4 patients already," now this is just on a regular floor, 4 patients per nurse, "there is a 7% increase in the risk of death." That's the end of the quote. So how would that make you feel if you go into the hospital and you find, or you should always ask your nurse how many patients she's caring for. And if you ask her and she says she's taking care of 7, 8 patients, the percentage goes up dramatically. Every patient she has over 4, it's going to increase your risk of death. And then in addition, each additional patient per nurse was associated with a 23% increase in the odds of nurse burnout, which is causing our nursing shortage, and a 15% increase in the odds of job dissatisfaction, obviously. Then she goes on to say, quote, "Physicians agree, citing inadequate nurse staffing as a major impediment to the provision of high-quality health care," end of quote. So the doctors agree. That doesn't mean they're doing anything about it, but they do agree. When this information came out, it did again hit the media. I think it came at a good time, and it has slowly, all this information has slowly accumulated, and the media, especially here in Champaign, has been very proactive, but it's not until the public itself each private citizen demands change, that I believe change will come. Right now, nearly 24 states are considering legislation on this growing hospital crisis. Recently, I testified in California for the Department of Health Services, encouraging the state to quickly enact a bill that was signed by Governor Davis 2 years ago, to implement safe staffing ratios there. Actually, in California, in 1975, they passed the first law stating that in the intensive care units it had to be a 2-to-1 or 1-to-1 ratio, and that was more than 25 years ago. And as a result of that, a Maryland study in 1997 determined that in hospitals where the ratios of ICU nurses was 1-to-3 or greater, and 1-to-3 is what they do here, the patients had a significantly higher rate of medical complications or a longer hospital stay in comparison with the 1-to-2 and 1-to-1 ratio. So I feel it's important that we, everyone, educate the public about the healthcare system, their rights and their need to speak up for themselves and their loved ones. And hopefully you or one of your loved ones, next time they're in the hospital, there will be a registered nurse to take care of you. And then later on we're going to talk about, I think, the difference between LPNs and RNs, or whenever you want to do that.
Yeah, we'll talk about some of the distinctions.
Right.
Next, Pat is going to do her demonstration, which helps to bring to clarity why, when you're talking about the staffing ratios 4-to-1, why exactly that matters. It helps make it come alive. So you can go ahead.
Okay, hi, I'm Pat Weddick, and I'm a registered nurse, and I've worked 12 years in the intensive care units and in the emergency room. And what I want to just describe to you is, if you can just picture yourself in this scenario, is that you this morning woke up from bed and you had chest pain. You came to the emergency room and you were admitted to the hospital. Now you're in the intensive care unit and I come on, and most of the nurses work 12-hour shifts in ICU. So I come on at 7 p.m. because I do the night shift and I'm your nurse. So the first thing I do is I walk into your room and I immediately need to scan the entire room. What I need to do is I'm looking at the monitor, I'm looking at you, I'm looking at the equipment in your room, and I need to decide what my priority in taking care of you is going to be right then. So the first thing usually I do, if there's not a crisis going on, is to walk up to you, introduce myself. I need to do a head-to-toe assessment on you. That's the only way I can judge how you're doing. So I start with things like, I check your pupils. I look to see if they're equal and reactive. I need to see if your speech is clear and appropriate, if you're oriented to where you are. I touch your skin because I need to know, is it warm and dry? Are you sweaty? Are you pale? Are you not getting enough oxygen level? I listen to your lungs. I need to know if they're clear. Are there any sounds that shouldn't be there in listening to your lungs, listening to your heart, listening to your abdomen? I move down to your feet and I touch your feet, and it seems a very strange thing when the nurse goes down and she puts her hand on your feet, but what I'm doing is I'm checking the pulses in your feet because I know that's the farthest place from your heart, and if I have an adequate pulse in your feet, that usually means that I'm getting adequate perfusion to your brain, to your kidneys, to your lungs, to your heart, which are your vital organs. After I do that, I'm looking at your IV medications that you have hanging, and you're on a heparin drip, which I know is a blood thinner, in the case that you have a clot and you're having a heart attack, which is what we're ruling out here. You are also on a nitroglycerin drip because I know that this increases coronary artery dilation, increases the blood flow and the oxygen supply to your heart to try and decrease the risk of injury. You might also be on a dopamine drip because when you came into the hospital, your blood pressure was only 70. All of this caused by problems with your heart. I've drawn lab work on you, and I need to check the lab work, and I need to know what all the normal values on this lab work is because I need to know what your physician needs to be called about if there are abnormal labs. So after that, I also need to figure out, are the drips going at the right rate that they're supposed to be going? I have to know all the limits of those medications to know, is the amount that they're running at accurate and not over what the limit should be, less than what's adequate for you. So a little bit later, I invite your family to come in, and that is because they've been sitting out in the waiting room worrying about you all day, and nobody's really had time to talk to them because they've been busy with you. So I try to explain to them what all the equipment is, what we're planning to do with you, how you're doing, and to also reassure them that we're going to give you the best possible care that we can give you in the hospital. So after that, then you tell me that you're starting to have a little more chest pain again. I notice on your monitor, on your EKG, that you're having what we call premature ventricular contractions. I know that those are caused by sometimes not enough oxygen, and oxygen is a drug in the hospital. We treat it as such because it has so many effects on your body. The other thing I know is that it can also be caused by a low potassium level. So I'm checking your potassium level. I call your physician and I say, I'm hearing patient is starting to get a little bit restless. I'm starting to hear some crackles in the bases of your lungs. Your urine output has dropped now. And so he gives me orders to give you Lasix. I do that. Things start to improve a little, but as the night goes on, I notice that you're starting to have on your EKG some changes where you have ST elevations in leads 2, 3, and ABF. And for me, I know that that means that you're probably having an inferior wall heart attack. So I call the physician and tell him those things, and he decides to come in and take you to the cath lab. So while we're waiting for the physician to get to the hospital, because it's 2 o'clock in the morning and he's in bed asleep, I'm talking to you, and all of a sudden you become unresponsive. I look at the monitor, and you're in ventricular fibrillation. You have no pulse. You have no respirations. I call out of the room. I call a code. I have a team of people come in to help me. The majority of them are staff members that work with me. And so we know we need to do CPR. Immediately, we need to know what to shock you with. And there isn't a physician there yet because this just happened. We need to know how many joules of electricity it takes to shock your heart for the best chance to get you back. And we know that it needs to be done in less than 60 seconds for the optimal chance of survival on this. We're also pushing IV medications on you to try and also to restart your heart. We run this process for about 15 minutes. By then, the physician, the rest of the code team is all there in place. We get you back. They take you to the cath lab. At this point in time, I'm trying now to document everything that I've just done with you. Because everything that we do, if it's not documented, is a chance of a liability later. Talking lawsuits because people are starting to sue more in this history. So the other things I want to tell you is that the scenario I just described for you was probably into the first just hour to 2 of my shift. And what I've done for you, you are not my only patient that night. The standard for a patient of this type is to also have another patient paired with this patient. And to the public, they think that maybe taking care of patients is not very much work. But when you think about all the things we have to do, and I need to assess you every hour because many, many changes are going to be happening to you. That's why you're in the intensive care unit. But the scary part is what's happened now is in order to cut back costs, hospitals now more than ever are starting to add patients onto that. There are some intensive care units where the staffing ratio, the registered nurse has 3 patients. And now in some units she also has a 4th patient. When you look at the equipment in the room, I'm also monitoring about $100,000 worth of equipment in your room. I have to know how to time them, how to monitor them, how to troubleshoot them, how to make sure that they're optimally working for you to try and save your life. And what I want you to know is this, is that the course of your recovery, and a lot of times, depending on whether you live or you die, is dependent on the registered nurse at your bedside, what she knows and what she does for you, and what she communicates to your physician. Because he's not at your bedside in these times. The registered nurse is at your bedside for all the hours that you're in the hospital. That's the person who knows when small changes happen, when big changes happen. And that's why it's so important for us to be able to monitor adequately, and that's what nurses are complaining about now, is that our concerns have to do with not being adequately able to look at the patient. Say at any point in time I had not been in your room at any point in that course, maybe the outcome would have been differently. What if I had been in the room with another patient when you had stopped breathing and your heartbeat had stopped, and maybe it took us 3 or 4 minutes to get there instead of just being in there with you? You know, that could determine whether you're going to live or you're going to die. And, you know, the concerns that we have are that, you know, that we're just not able to take care of the number of patients that we have. A lot of the hospitals, because of the nursing shortage, And I want to tell you that part of the nursing shortage is dependent not because there aren't nurses out there. Many of it has to be is that nurses have left the profession because they are not willing to do what work under the conditions which are unsafe that hospitals are demanding in this time. The other things about that have to do with a lot of those nurses, and the concern is the majority of nurses really are in our age group. We went into nursing for different reasons in the times that we went into. And pretty soon, a lot of us are going to be retiring. We're going to be getting out of the profession. And I think what the public needs to be concerned about is who's following us and what is their knowledge level and what kind of dedication do they have and what are they being taught about what nursing is all about. And it's not just treating, the physical things. There's an intuition about it. There's something that you have to treat the whole person. You have to know who they are. You have to be able to treat all the physical symptoms, and you need the knowledge to know that. So when you put an LPN also even in the place of a registered nurse, in the state of Illinois, the problem is that a licensed practical nurse is not licensed to push IV medications, and they have to actually have their documentation all signed off by a registered nurse, the medications that they give. They cannot take phone orders from physicians. So you're talking about that if I'm working with an LPN who also has her own patient load, I'm also responsible for overseeing what she's doing on top of what I'm doing. So basically I have double the patient load, and that also is a concern. And patient care technicians in some places are being asked to do, and these are people that a lot of them are just high school graduates. They're looking for a job. They might be students in college. And, I'm not saying that these are stupid people. That's not it at all. They're just not educated in the way that the registered nurse is to know what things to look for. Some of the little things is that your technicians are allowed to walk your patients in the hallway. But I've had cases where the technician didn't realize the importance of the fact that the patient was on 6 liters of oxygen and needed that oxygen, to be able to maintain an oxygen saturation, get enough oxygen to their heart. And so that by the time they walked the patient, they just took the oxygen off and to walk the patient. When they returned to bed, the patient was blue, the patient was diaphoretic, their blood pressure was low, and then we had a crisis on our hands. But those are the kind of things when you don't have a licensed person at the bedside during the work. And I think that's what we're trying to get across is that I think people watch TV and they see nurses in the fashion that they're portrayed in television. But I'm going to tell you, just as a fact, as watching ERs, that I have yet to see a physician start an IV. Physicians do not push medications. Believe me, they do not shock the patient. They do not do the CPR. In those crisis cases, those physicians are directing the care, but they do not actually do it. And it is a very false impression to let the public think that the physicians take care of all of that and they save your lives, when truly it is a nurse that saves your life. Thank you.
Thank you. That brings up part of what we had wanted to talk about next is the different levels of staffing, and you already went into it a little bit. There is in your guide, people have your copy handy. It begins in section 2, page 4. It begins talking about the hospital staff involved in your care. And I think one of the things that we want to be very clear about is that every staff member at the hospital, every category, every type of staff member has an important and essential role to play. But it's very important that we don't confuse and think that certain staff should be able to do duties that are outside of their expertise or qualification or even their job description. And the changes that are happening in hospitals are such that, of course, the RN nurse staffing has been cut back. But now hospitals, and you can see examples of this locally, hospitals are now more sensitive about public outcry if they see too many nurses being cut. So now hospitals are talking about cutting ancillary staff, as if somehow ancillary staff are like and that's just trimming the fat, as opposed to that's part of the muscle of the hospital. Cuts in ancillary staff also hurt patient health and safety and the capabilities of nurses to do their jobs, because if ancillary staff, which can include, I don't even know what the term means, I can tell you some of the categories. It includes sort of a squishy area, but it can include housekeeping staff, it can include secretaries, things like that, and those staff members have important roles to play, and just because they go away, the need to do the jobs that they do doesn't go away. And if they go away, then other people are picking up more of the burden. For example, nurses, sometimes hospitals will euphemistically talk about that they have increased nursing hours at the bedside. And that sounds good. It sounds like an RN is standing there longer with you, but really what that can mean is that the RN is in that room with you, but maybe she's cleaning the bathroom or your bedpan, or doing things that are important to do and somebody needs to be doing, but if she's the one doing it, it's taking her away from doing the things that Pat was describing that need to be done. So that's why it's important for people to understand the distinctions between staff, and to sort of understand that in general, cutting staff in a hospital really isn't okay, especially as a cost-cutting measure. In this handout, there's a listing of different types of staff. It talks about the registered nurse, the licensed practical nurse, or LPN, the nurse's aide, which is what was referred to in the video and what Pat talked about, which are called many different things: technical partner, patient care assistant, healthcare technician, clinical care partner, patient support associate, and all kinds of other names. And then there are also housekeeping and service partners. And this handout describes just some of what those folks do, but everything they do is important, and all of their jobs matter, and everybody needs to be working under good conditions, because it all ends up affecting patient care and nursing within the hospital. And then there's some more information there about different types of staff and what a well-staffed hospital will have on hand. For example, we had talked about that a well-staffed hospital will have a phlebotomist for each unit, or an EKG technician for each unit. Because if they don't, do you want to talk a little bit about like when an EKG is needed and what happens if it's a nurse instead of somebody else?
Sure. Use your scenario, yeah.
Well, one of the things is, and I do want to impress upon you that every single person, we are totally dependent on everybody that works in the hospital. Pharmacy, your EKG person, your blood drawers, your housekeeping. Everybody is an integral part of taking care of the patient in the bed. But one of the things that is, like, for just as an example, is an EKG. If someone comes into the hospital with chest pain, generally if they come into the emergency room and they say, I'm having chest pain, ideally speaking, you really need to have 3 to 4 people just zooming in on that person, and somebody needs to be drawing their blood immediately. Somebody needs to be doing an EKG to look at the rhythm to see if the patient's having a heart attack. Somebody needs to be starting an IV, somebody needs to be putting on oxygen, taking care of all of these things. Well, what happens is, okay, if you take away the EKG technician and you don't have them, and the nurse is concerned with starting the IV, giving stat medications that need to be given, doing the things that directly affect the patient care, and the EKG gets put off, there are many changes that happen when you're having a heart attack that may happen in just moments, and then they're gone. That's why you need to immediately do all of those things. So, because your EKG is changing, you might miss something that has happened to the heart by putting it off. So if you delete the EKG technician, sometimes what happens is the EKG sits in the rack, the order for it, and maybe you don't get to it for half an hour after the patient's been there, just because priorities say that the first person you need to take care of is the patient in the bed. So an hour later, maybe you've missed something that's happened acutely, and you need to be treating it. You need to be doing things. We give what's called clot busters. You need to know if that patient's criteria meets the fact, should they be getting thrombolytics, should they be getting blood thinners, what we need to be giving to try and save as much heart muscle as we can from being damaged. But each person that you take away from that bedside, you've decreased the quality of the patient care.
Does that help illustrate for people, like when you hear like the studies that Faith went through that first said 80, some as high as 98,000 preventable deaths, hospital deaths every year. That's part of how that happens. But then the studies sort of over time zeroed in on what accounts for the most, of this, and it has to do with the changes in staffing level, and in particular with taking RNs out of the picture and having more other people there, but overall the staffing levels being down. And so scenarios like that, like with the EKG, or when you were giving the ICU scenario, I was thinking, what would happen if both your patients went into crisis at the same time? Where do the
Which
teams come
happens.
from? Yeah.
There
And where
needs to
do
be
the,
some flexibility in the staffing for these crises. In some hospitals, you see that they are just staffed to the minimum by sending home the extra nurses if they think they don't need them. Then if 2 patients on one floor have a code, stop breathing or have a heart attack, there aren't enough nurses on that floor to take care of both those critically ill patients. There has to be flexibility in the staffing.
yeah. In the guide on page 7, it gets into talking about the different ways or strategies that hospitals use to cut back on staff, and then how those cuts affect nurses. And I won't go through that now, because we've already talked about that a little bit. But I think the important thing is to understand, from Pat's demonstration, the importance of the RN at the bedside, but then also to understand the role of the so-called ancillary staff, and that if the ancillary staff are cut, that takes time away from the RN for her to do her job, and the chances are that already her unit is understaffed in terms of RN, or RN to patient ratio. Section 4 is, Section 4 and Section 5 are sort of more the community education information about the ways that hospital administrators talk about staffing levels, and hopefully now you can decode some of that and figure out ways. We also give suggestions for ways to ask and get information about staffing levels. But hospital administrators typically make statements about that they've increased nursing hours, but they don't define what nursing means or who is doing it, or whether it involves direct patient care. So they can refer to people who have RN degrees but aren't performing registered nurse functions in the hospital in terms of direct patient care. They can sort of conflate the numbers by adding those people in. They can also talk about increasing nurses' hours at the bedside, which we had talked about, before. And then it actually lists, about 7 different ways that hospitals actually calculate their numbers to inflate the nursing staff, or make it seem like there's more nursing staff than what there is. And these are some of the, I don't want to call them tricks that they use, but they really are sort of like tricks that they use. And so these are the kinds of things that you need to be aware of when you ask questions about staffing levels. The most basic way asking about staffing levels, first, be aware of the tricks. Be aware of who counts and who doesn't count, and that when you're talking about nursing, that you really want to know about RNs at the bedside involved in direct patient care. And if you're a patient in the hospital, or somebody you love is in the hospital, you can ask, who is the registered nurse at my bedside tonight or today, and how many other patients does she or he have? And that's one way of getting a feel for your situation right there. LPN should not be included in the ratio, and nurses will tell you directly, won't they, for the most part? The nurses will tell you directly. The thing that's harder is when you're trying to get more basic information from the hospitals in terms of what's their nurse to patient staffing ratio. I mean, I doubt anybody will be able to get that. I mean, that's something that has to be researched, but you can ask those kinds of questions, but just when you get the answers, you have to sort of decode them. Now by nursing staff, do you mean RNs, or are you including LPNs? You have to sort of wade through whatever they tell you. If you can't get that kind of information, there are other indicators about patient health and safety which sort of point to staffing levels and patient mortality issues and so on. and you can ask about, actually some of the things that they talked about in the video, where you can ask about rates of readmission. Why are rates of readmission important? Rates of readmission are important because if they're high, it might signal that patients are actually being discharged too early, to save money or whatever, their insurance is running out or whatever, but patients being discharged too early, or patients being sent home with an infection or some kind of complication or something that has gone untreated. I don't know if there's other.
There's another very significant one there, patients being sent home without enough education about their post-hospital stay. For instance, if they're sent home with a particular kind of drain, if the nurses don't have time to give them the proper, we call it discharge information, discharge teaching, that really increases the rate of readmission, because the families don't know how to take care of these things, dressing changes and such.
Yeah, education is primary. You need to be able to have the time, and it's very time consuming because, a lot of times you're talking about someone who doesn't have a medical background about their illness. You need to explain to them very carefully about what things they need to avoid, what things they need to try to do, what the signs and symptoms of complications could be. And you also need to assess, is that person going home to an environment that's conducive to them even being able to follow your rules? Can they afford the medication that you've prescribed for them? Are they actually capable of doing the dressing changes that they have to do? Is there somebody in the house that can administer the medications that we've sent you with? And sometimes that's not the case.
We've had,
and that increases readmission.
yeah, we've had actually cases, and one of the things I'm thinking about is like when my mom got sent home, she had a mastectomy, and she got sent home, and she has a medical background, so does my dad, so they were able to care for her. But just the trauma of having to look at and take care of her wound and dealing with the drains and things like that, and if she didn't have the medical expertise, I don't think she could have done that. But we've had cases where we've had people actually discharged early who probably should have been on IV antibiotics, were like one with his arm and one person with their abdomen actually open, completely open, and because they were still healing up from an infection that they had that had to be irrigated and stuff like that. And those people shouldn't ever have been sent home, and they did end up having to go back to the hospital. But things like that, and those are recent cases here in this community. Patient mortality rates, of course, and then also hospital-acquired infection rates, pneumonia, urinary tract infections. Did you want to explain urinary tract infections?
Well, one of the things we talked about is when you change your patient to RN staffing ratio, these are some of the little things that people don't actually really think about because they seem simple, but they're not. Okay, say you have a post-operative patient and the doctor's order is to walk the patient 4 times a day. Well, you come in at night and you have 9 patients and you know that that patient's already walked 3 times today. So you say to yourself, oh well, we can just skip the 4th walk tonight, it's not that important. But if you add that up every day, and the thing with urinary tract infections are, a lot of people have catheters, and you have to talk about, are they draining adequately? Is the patient getting good personal hygiene care that they can't do for themselves? Are these things being taken care of, or were you increasing the risk of them acquiring an infection from being in the hospital? The pneumonias that are hospital acquired. The simple thing is patients that are not able to, can they do their own mouth care? Are we keeping them clean? Do we have time to keep them clean? Patients that are bedridden, that cannot do for themselves. We need to be turning them every 1 to 2 hours, from side to side to prevent skin breakdown. Well, if you're really busy, maybe you only get to that every 3 hours, or every 4 hours you only get to turn them. So they're laying on one side for too long, and what happens is skin starts to break down. They get an infection in that wound. That increases your hospital stay. It increases their mortality. And those are things that happen all the time, and those are higher risks from having poor staffing levels.
Do people have any questions or experiences that?
The other thing is that you need to think about the fact that people they think about all the things we're saying. They say, "Oh yeah, but that doesn't affect me. It doesn't." But everybody has parents grandparents. There's not a single person in this room who one day, if they live long enough, is not gonna end up in a hospital at some point. So you need to think about what is acceptable to you in the care that you receive, or the care that somebody you love is gonna receive.
I know you mentioned that in California that the hospital administrators were doing their jobs. What do they need to do? Every hospital is going through these budget constraints, and how is one hospital able to have these nursing?
This is a question I've posed repeatedly. How come some hospitals are managing financially and others aren't? In California, the staffing ratios are legislated, it's by law, that we have to staff appropriately. But I have worked in many, many hospitals, and you can see, I'll say, financial wastage in many hospitals, be it in their entryways, which look like Grand Hotel, would you say? Like horrible. Or advertising, or spending too much money. I worked in one hospital which spent tens of thousands of dollars on a computerized program that crashed the first day it went up and running. They hadn't done the research. And the hospital I work in California, which is the 7th best in the country, it looks in some respects like a third world country, but it doesn't have all the glitz that like Carl does. It's a teaching hospital, very functional, but the money goes to nursing and to, for instance, the patient care rooms are wonderful. The mattresses are state-of-the-art mattresses, but the nurses don't have lockers, we don't have a place to eat. So some people could complain about that aspect of it, but the money is going to patient care. I think it's all how they decide to spend their money. CEOs of some of these hospitals make up in the millions of dollars too.
Also, there's actually, a lot of hospitals are now talking about, and health systems are talking about, the Medicare cuts, that's like why they're financially strapped. And that's actually sort of a myth. The Medicare cuts did take place and have affected hospitals, but hospitals knew those were coming for 5 years in advance. They knew that, so they should have been able to plan for that. And actually, some studies have been done that have shown that the decreased revenues to hospitals are actually more of a result of managed care contractual agreements, like HMOs, than actually the Medicare cuts. So when I think that has implications for like our local healthcare system, which is so intertwined with the managed care, system. But that's part of what's happening a lot is hospitals contracting with managed care to become the provider, but also at a discount rate and so on. So some of those things are, are business decisions that on the one hand underestimate the cost of providing real care, but on the other hand, when there's sort of a profit motive and so on, it's difficult, even among nonprofit hospitals. And another thing is there's actually a study made reference to in your guide, but the Federal Trade Commission has been looking into all of these hospital mergers and these combinations of healthcare systems that started right around when, for example, Prevena started. That was like right on the cusp of the national trend for all of this. And all the promised results of these kind of mergers, economies of scale and all kinds of things, have not proven out. They just haven't proven out. They haven't improved quality of care. They haven't saved money for communities and consumers. We can see that here. Our healthcare costs have not gone down. They've gone up, and they've gone up way above the rate of whatever the Medicare cuts are. But you see, profits or excess revenue still being funneled to the parent corporation. And I don't want to go into the whole Prevena personal care thing, but that's a perfect example. We're going to see another example of that coming up shortly, as I think just yesterday it was announced that Prevena Covenant is merging with Danville Good Samaritans Hospital. They're merging them together. And one of the considerations for our community about that is that we've been told that Covenant is a financially strong hospital, which it certainly was before Prevena took over it. We have the financial data on that. It was actually a very healthy hospital. Danville Hospital is not so strong, and in fact, recently they made layoffs supposedly because of financial reasons and so on. So, we're shouldering the tax burden here in this community for Prevena Covenant, but are some of those assets, rather than being reinvested in our hospital and building up the staffing levels and so on, are those going to go to shore up a financially strapped hospital? So there's all kinds of considerations. like that. But all of it is moving away from the primary focus of, that hospitals exist for providing nursing care. And that's where the investment ought to be. So, I don't know if there's any other,
What justification would there be, if any, for Diane Friedman's statement that these changes increase the quality of service to the patient? What could she, in what way? I don't know.
Well, and this is way back, the original model for reengineering, in theory, was really a good model. But what happened was, there was never a time when we were able to hire enough staff to fill the levels in their model. So that what you start out behind. We never ever reached the goal of staffing those models the way that they were set up. So you failed immediately because you never even started with what your goal was.
Tell us what the basic staffing was, the team.
Yeah, the original team concept was for each team that took care of a set of patients, say you were going to take care of, and I was approximately 6 patients, but you had, for each 6 patients, you had a registered nurse at the bedside. You had what we call was a technical partner, which was somebody who helped to do the vital signs and to help walk the patients and to help take them to answer lights and things. And then you had a third person in that, which is a service partner, which was your person who was helping to do the things like helping to clean the rooms, put in orders on the computer, and do all of those things. So for a team of 6 people, you had 3 people assigned to your team. But what ended up happening is we never ever were able to hire enough service partners or technical partners or registered nurses to make that model work. So say on where you should have had on, if you had 18 patients, say on a floor, you would have had 3 teams of 3 people each taking care of those. But what happened is that, okay, maybe you had 3 registered nurses, maybe you didn't, maybe you only had 2. But you only had 2 technical partners. So you end up splitting those teams so that each of those technical partners now has 9 patients each. And maybe you only have 1 service partner for the whole floor, so that person is taking care of all 18 patients on the floor. We never met the model. Could it be successful if we had? Yeah, I think it could have been very successful, but we never ever were able to meet that model. And that's why she's saying it was a good plan, but it never worked.
okay, well, why don't we go ahead and close up? If people want to stick around and ask some questions or talk a little bit, you're welcome to do that. Thank you very much.